right, we're good now. Welcome to the show. My name is Winnie Lubembe. It's your world. Apologize for that technical hitch and for starting late. But here we are, and we are about to have a very important conversation this morning. And this is as far as small, vulnerable newborns are concerned. And like we all know, 1 in every 4 babies in the world is either born too small or born too soon. And they account for 1.9 million stillbirths and 1.4 million newborn deaths annually, and this is especially in sub-Saharan Africa and, of course, Asia as well, Southern Asia as well. So the survivors are vulnerable to health problems throughout their life course, affecting human capital, economic productivity, as well as healthcare costs. So the big question is, how can we reduce prevalence of small, vulnerable newborns in the East African region and across the globe as well, because this is a problem that affects so many people across the globe, and newborns to be specific. All right, so that is the subject of our conversation this morning, and to help us very quickly, on my immediate right is Dr. Eric Ohuma, who is an associate professor, London School of Hygiene and Tropical Medicine. Good to have you this morning, Dr.
Thank you.
Thank you so much for sparing your time. And we also have Stella Mwikali, who's a champion mother from Pumwani Maternity Hospital. Good to have you this morning as well, Stella. Thank you for your time. And Dr. can we just get basics covered? And this is on small, vulnerable newborns. What exactly does that mean? Because majority of the times we usually talk about premature or preemies. Most people know about that. But what do we mean by small, vulnerable newborns?
Thank you, Winnie, for having me today. So I think the concept of small vulnerable newborns is a new concept in kind of maternal newborn child health space, and essentially it emanates from indicators that we've been tracking for the last 100 years. Okay. And I think a lot of people are aware about low birth weight as an indicator that people track over time. Most people are also aware about preterm birth, which is another indicator that is of relevance. Yeah. And then there's this other new indicator which is coming up relatively new, which is called small for gestational age. All right. And when you talk about small vulnerable newborns, essentially what you're saying is you're actually saying that actually we know that newborns can be low birth weight, but also preterm. Okay. So I think the small vulnerable newborns is really looking into the granular details of combinations of low birth weight, preterm, and small for gestational age. And I'll try and break this down. So if you think about low birth weight is usually defined by a newborn who's born less than 2.5 kilos. Okay. So that's just a birth weight. All right. Preterm birth is defined as a newborn that's born before 37 weeks of gestation. Yes. So the important element there is gestational age. All right. So if you bring those together, so you're looking at, if you're able to look at indicators of birth weight and gestational age, the combination of that can actually then give you even more granular types. So you can have somebody who is low birth weight, but also preterm. And I think what we've come to realize is obviously if you look at rates of, for example, mortality, the mortality is uneven across the different newborn types. Right. So what small vulnerable newborn types is newborns is trying to do is to really understand where the highest risk is. There's been a huge global effort in trying to do this. There's lots and lots of multiple partners who've been involved in trying to do this. And this is the first time that this has been done. We're very glad that this concept was conceived about 2 years ago with a network of global champions, but also very grateful that the Lancet were willing to be able to showcase this. So I think what is really I think is important is being able to, if you're thinking about interventions, not just focusing on very let me say binary indicators that we've been focusing, like low birth weight or preterm birth, but really understanding where the vulnerability actually lies. Okay. So the concept of small for gestational age usually combines birth weight, the newborn sex, and gestational age. Right. So what we've actually done is look at the different combinations to obtain the different types. And then by understanding that, we can then link that to mortality. We can understand where the most vulnerability is. And then hopefully we can be able to get the right interventions for this small vulnerable newborn types.
Absolutely. And we'll talk about then the interventions, and this is proven, right, by research and all those things, just to see. And we're looking at preventable aspect of the same, so that we don't just wait until the problem is here, but what can we do to prevent some of these problems? So one might ask, so then what brings about the same, and this is SVN in general? What brings about it? Is it maybe complications during pregnancy? Is it something most of the time that moms would tend to ask themselves, did I do something to lead to the same case? So very quickly before we speak to Stella.
Yes, no, that's a good question. So I think, and again, there's a lot of factors that could lead to a newborn being classified as SVN, a small vulnerable newborn. And a lot of those are, multifaceted. You could think of, for example, undernutrition is one aspect. So undernutrition, which affects pregnant women. So that could lead to issues like anemia, for example, calcium deficiency. Having a low BMI as you're starting your pregnancy has been shown to be associated with adverse outcomes at birth. Low weight gain, for example, which is also an important factor. There's also infection, which we know, for example, in our settings, infections such as malaria, HIV, which again impacts on the pregnancy outcomes. There's also other indicators such as other morbidities like preeclampsia, which is also again very prevalent especially in African populations. Gestational diabetes, hypertension. There are also other characteristics which I think are more social constructs. So if you think about short birth intervals, for example, whereby if a woman is having children within a very short period of time, I mean, studies have been done and shown that actually if you have short birth intervals, you're more likely to have adverse outcomes as well. We know that the risk of adverse events is also quite high amongst the adolescents, but also the very old. And again, I also wanted to bring this because I know Kenya or Nairobi was quite privileged to actually host the Africa Summit on climate. So there's also a lot of things or studies that have shown that other exposures such as air pollution, which is important. And these are things that probably are beyond our control at the individual level, but actually have impacts on the pregnancy. There's been studies showing the impact of heat on pregnancy outcomes, but also other things that we can probably do something about, especially like, for example, alcohol intake and smoking as well. So those are some of the things that could lead to higher risk of an SVN. So that's just to mention a few.
Okay, I like that. And we'll come back to then what do the numbers look like, and especially in Kenya and across the region. But before that, can we quickly speak to Stella? So Stella, let's go back to 2018. You delivered your twin babies, okay? But there was something that happened that you're also in shock. You were like, no, but they cannot be this small, okay? So do you want to take us back to 2018? What happened?
Okay. In that 2018, nilijifungua watoto wawili.
Okay.
Na hiyo mimba ilikuwa na miezi 6. Na sikuwa najua kama naweza nijifungua na miezi 6. Na funny enough, sikuwa najua kama ni twins. Sikuwa nishaienda kuangaliwa. Nilipofika pale nikazaa mtoto wa kwanza, alikuwa na 1.2. Wa pili alikuwa na 100 grams.
100 grams?
Yeah.
Okay. All right. So, so like, what was the first thought? The two, and especially the one, the second one with 100 grams. What was your initial
I was shocked because in my life, sikuwa na expect kama mtu anaweza zaa mtoto wa kilo moja. Na si eti hiyo kilo moja alikuja akakuwa na shida ya kupumua. Akareduce hadi to 700 grams. Pale ndo daktari mwingine akakuja akaniambia kuna kitu inaitwa kangaroo mother care style.
Okay.
Hiyo ni kuweka mtoto skin to skin. Unatoa mtoto nguo na pia wewe bila nguo ya juu unamweka. Ngozi yake na yako zinanguzana.
Okay.
Yeah.
All right. So we'll come back to understand more on the same. But nataka kujua, so before the 6th month, at what point did you know that, first of all, you're pregnant? Because like you said, uko umeenda hospitali within, all this period. So hata uko unajua at 6 months that umebeba twins. So meaning that hakuna scan ilikuwa imefanywa, si ndio?
Nilienda clinic, but sikuenda scanning.
Okay.
Nilienda clinic na mimba ikiwa na miezi 5.
Okay. That was the first time ulienda?
Yeah.
Okay.
Sasa hii ya pili nilikuwa nangoja niende clinic ya pili na niende scan. Hiyo ndio result nilipata.
Okay.
Yeah.
All right. Doctor, do you want to comment on the same? Because majority of the women will tell you, first of all, I didn't even know I was pregnant until the 3rd month or the 4th month. Or others would say, fine, I am pregnant, but I will go when the pregnancy has sort of advanced. Is that in itself a risk?
Yeah, I mean, I think that's one of the key challenges I think we are battling with, I would say. I think one of the key recommendations that we really, I think as a nation, but also as a region, that we really need to push is early access to antenatal care.
Okay.
I mean, that's imperative. I think that's when we're going to start having any gains. So I think there's a multitude of issues. Obviously, we need to find ways that we can get our women to access antenatal care early enough. That has huge benefits. One is obviously if you are able to appear to a facility which has ultrasound facilities, then we are able to accurately date pregnancies, which is important, but also we're able to monitor pregnancy. So in the case of Stella, it would have been very easy to pick up that she is having twins. And we know that there are also risk factors associated with having twin pregnancies. And that would have been flagged up, and appropriate care in terms of closer monitoring and follow-up would have been initiated if that was the case. So I think one of the things that we really need to figure out is how do we bring our women to have access to antenatal care early. But the second thing, which I think has been a barrier, is access to ultrasound, which remains a barrier. So I think there's a lot of innovation that's going on at the moment, particularly in having point-of-care ultrasounds, which again I think will be really, really key. So this can be deployed at the very basic level in communities, but also in rural areas. But also I think alleviating the need that such technologies don't need to be done by, for example, trained sonographers. They can actually be deployed by community health workers, for example. So I'm very pleased that there's a lot of work that's going on in this space, and I hope that this is going to be, I think, revolutionize maternal care.
Yeah.
So in the case of in the case of Wikali, I think, if she has had access to access early, obviously that would have picked up. Access to a facility which had ultrasound, again that would have been picked up early. So I think that's why we need to start the conversation.
Absolutely, and we'll come back to you to understand. So what usually happens, and this is as the pregnancy progresses, and it's very important what you're saying, that women should should access healthcare facility, and especially when we're talking about antenatal care, it's very, very important. So we'd want to understand, so what could be picked at what point? And this is in terms of like complications either for the baby or during the pregnancy. But Stella, very quickly, I just want a clarification. So scan haikufanywa because there was no ultrasound machine, or why wasn't it done? Because I want to believe by 5 months the doctors would have been able to fix it or compare, okay, so let's see what is going on up and down with you and the baby as well. So is it that hakukuwa na the facility ultrasound machine? Okay,
kila kitu ilikuwa ni ile sikuenda.
Okay. Okay. And also we have a lot of women who say, mi sitaki kuenda kwa sababu sitaki kujua the sex of the baby. I want to sort of like be surprised. So I wonder if that was the case as well for you. Was it a case of finances? What exactly was the reason?
I can say everything nilikuwa tu sawa, but ni ile tu
Okay, no, it's totally understandable. It's totally understandable. And was this your first pregnancy?
Yeah.
Okay. All right. Because Dr. we see this with a lot of like first time, moms. And like you're saying, so when should women start going for the antenatal care? Because I've had a lot of, doctors and gynecologists will tell you, please go before. When you're planning to get pregnant, get yourself to the hospital, get checked, to see how everything is before you get pregnant.
Yeah, no, thank you. So I'm probably privileged that I was involved in an international study called the Intergos 21st study, which was really contributed a lot of work in understanding, what happens during pregnancy. So looking at pregnant women in the very early stages, monitoring the growth of their fetuses, and this was across 8 populations across the world, with women who were carefully selected to be healthy. And the reason for that study is we wanted to really understand what can be achievable in terms of what is the optimal human or fetal potential if you have a healthy pregnancy. Okay. And I think that sets the scene in terms of knowing this is what we can achieve if we're making our women going through pregnancy as a healthy start. And through that work, we've been able to publish what we think are the international standards for fetal growth, newborn growth, and also for preterms. In terms of and circling back to that, is I think that we really need to, for women, they need to access ultrasound very early. Okay. And the recommendation, I would say that ideally women should access ultrasound before 14 weeks of pregnancy. Okay. And we know that's a challenge, especially in the continent. So other guidelines such as WHO, would say that so long as women are able to come for their care by about 20 weeks, then that's probably appropriate. And what's the reason for that? So one key thing is dating of pregnancies. And this is a challenge because if women come early in gestation, we are able to accurately date the pregnancy. And that's important because then we know what your due date is. When we talk about indicators such as preterm birth, which is defined by gestational age, then we really need to make sure that the gestational age is accurate. So if we have inaccurate estimates of gestational age, which means we can't even classify appropriately whether the newborn is born preterm or not. So I would say that we really need to push the needle and advocate for women to access ultrasound before 14 weeks of gestation. At that point, we are able to accurately date the pregnancy and also do some scans. And I think with the current technology that we have, you are actually able to tell if the pregnancy is viable or not. There are other conditions which are able to be picked up by the technology that we have in ultrasound. If you go further up to, say, less than 20 weeks, that is still good enough. We are still able to get very good estimates of gestational age. But also that's a critical point because actually at 20 weeks, you are able to tell the sex of the baby as well if that's of interest. But also that's a point whereby we are able to also determine scans such as abnormality. If there's any abnormalities with the fetus, they're able to be picked up by 20 weeks. So obviously you want to know if the pregnancy is going to be viable or if there are any sort of congenital malformations. Those can be picked up by around 20 weeks. That's why I think there's always a drive to make sure that women come in early by about 20 weeks. And then I think anything that happens after that is then being able to monitor the pregnancies. And depending on whether that pregnancy is categorized as being high risk or low risk, that can necessitate either frequent follow-ups using ultrasound because you're aware of the situation, you're able to monitor it. If it's a healthy pregnancy, no issues, then I think the follow-ups don't have to be as intense as possible. And I also wanted to highlight that actually if you look at the WHO guidelines, I think the recommendation is to have at least 4 antenatal cares during pregnancy. So I would advocate for access to antenatal care before 14 weeks, because I think that's the standard. And if it's less than 20 weeks, I think that's also good enough.
Okay, all right. And we'll get to then understand. So with these complications, what could happen to the baby in terms of their growth and development as well? Because Stella was watching, one of your video stories that you've done, and you said first of all you were scared. Unashanga sasa mtoto ni mdogo, what do I do? But again, like you said, you were taken through kangaroo mother care and all those things. And even aside from that, ni nini ingine ulifunzwa to take care of this baby just to make sure that ana grow the same way as, the first born, because they're separated by a few minutes, right? So the first one and the second one, and how they're doing right now. And again, Dr. will come back then to understand, so what are some of these recommended, interventions that should be there so that we prevent cases of the same. But we're taking a short break. Stay with us. The show is Your World. See you very shortly. So much to come on the other side of the break. All right, welcome back. The show is Your World, and today we're having a special focus on small vulnerable newborns, and we're looking at some of the preventive interventions to curb pregnancy complications and child mortality rates at the same time. And according to the World Health Organization, they're saying an estimated 13.4 million babies were born too early, and this is in 2020, and that is more than 1 in 10 babies. And again, continues to say approximately 900,000 children die in 2019, and this is as far as complications of preterm birth is concerned. But again, today we're focusing not just on preterm, but we said what? Small, vulnerable newborns, okay? And there are 3 key areas that we're looking at, and this is, yes, there's that aspect of preterm, there's small for gestational age, but at the same time, low birth weight. And Stella is here, Stella Mikali is here this morning to just, first of all, tell us her story and her experience, because she had twins in 2018. They were born at 6 months, all right? And the first twin was at 1.2, right? And then the other one was 1 kg, right? That is 1,000 grams. But you said walipungua, oh no, the second one, walipungua had 700 grams. Okay, so we'll come back to you to understand how are they doing right now. Some of them are 6 years now. Wako shule. Already. But before that, yeah, grade 1. Okay, all right. But before that, Dr. very quickly, I asked this earlier on, and this is the numbers. Kenya and the East African region as well, and even global figures. How are we doing as far as SVN are concerned?
Yeah, thanks very much. I think I'm quite privileged that I was one of the team members who was involved in the global estimates of small vulnerable newborns, but also actually an update of the global estimates for low birth weight, and also an estimate of global estimates for low birth weight.
Yeah.
So our team, amongst others, so London School of Hygiene and Tropical Medicine, Johns Hopkins, WHO, UNICEF, and other partners have led this work. So we now have updates of what the current situation is globally of low birth weight. We looked at trends over time from 2000 to 2020. Similarly, we've done the same for preterm births. So we've updated the global estimates for preterm, again with the same partners, and also looked at trends from 2010 to 2020. And then subsequent to that, we've then been able to coin this SVN and also give an estimate. So I'm very privileged that a lot of people have contributed to this work. As a statistician, I think that as a statistician working in the maternal, newborn, and child health space, I think that we are not able to see what interventions are appropriate for societies without understanding what the problem you're dealing with and the extent of the problem. So I think the numbers are important because it really puts to light what you're dealing with. And then hopefully that should help in deciding what interventions are required. I think the statistics are shocking. So at the global level, which I'm going to start at the global level, about 287,000 women die during and following pregnancy and childbirth in 2020. So these are new estimates that have come up. 287,000 women are dying just to try and bring a new life. I think that is shocking.
That's very concerning, yeah.
It is very concerning. And if you want to break this down even further, this actually equates to about 800 women who are dying from preventable causes related to pregnancy and childbirth every day.
Oh, wow. No.
800 women every day.
That should not be happening.
And as you're sitting here, Winnie, I can tell you that we are having a maternal death occurring every 2 minutes.
Oh, wow.
Every 2 minutes. So by the end of the show, you can do the maths.
Right, yeah.
So that's at the global level. If you try and a lot of this, and I think the shocking statistics here, that is the global level. A lot of these numbers I've quoted, 70% of those are in sub-Saharan Africa.
Oh, wow.
So in as much as you're talking about at the global level, really the burden is in sub-Saharan Africa.
Yeah.
So I think sub-Saharan Africa is contributing 202,000 maternal deaths every year, which I think it just illuminates the kind of problem you're dealing with. And in trying to bring the local picture, the local picture is a bit grim, especially for Kenya. So looking at the data for Kenya and East Africa, actually Kenya is the worst performing country in as far as maternal mortality is concerned. We are doing much worse than our neighbors. So, and I don't know, it's hard to explain what the reason is because, rates of maternal mortality are almost half, for example, in Uganda, half in Rwanda, and Kenya is the highest in terms of maternal mortality in the region, which I think is really shocking.
It's very shocking because, I mean, when you compare our healthcare system as compared to our neighbors, we're much better. one would assume.
That's the belief. I mean, we've always boasted of Kenya being
the leader
in East Africa and even in Africa. And I think our statistics, especially regarding our women, are really shocking. So we're definitely doing a disservice to our women and girls. And I just wanted to kind of bring maybe just a perspective. So, for example, we know that there's been successes in other regions. One of the first regions that has actually led to huge reductions in maternal mortality is Eastern Europe, where they've had 70% reduction in maternal mortality. This is between 2000 and 2020. Southern Asia, which is usually Sub-Saharan Africa and Southern Asia, contribute towards most of the burden of neonatal mortality and others. But actually, Southern Asia has been able to have reductions in maternal mortality of 67% between 2000 and 2020. So that to me is actually shocking. Let's talk about the continent. So the Sub-Saharan Africa. So Sub-Saharan Africa between 2000 and 2020, we've only seen a reduction of 33%. So again, if you're following, you'd see that actually 33% is only half of what's been achieved in other regions, even though we have the highest burden. We are now talking at, so when you talk about maternal mortality, the statistic that is usually used is what we call the maternal mortality ratio, which is basically just the number of women who are dying of pregnancy-related deaths. At the global level, that stands at 355 per 100,000 live births. In Sub-Saharan Africa, that's 536 per 100,000 births.
Not good.
In Kenya, it's 530 per 100,000 live births. So again, I think looking at those statistics, and especially for Kenya, I think there's a lot more that needs to be done. But also maybe learnings from our neighbors, because if the statistics from our neighbors are almost as half as what we have in Kenya. So I think maybe there's some cross-learnings and understanding what Rwanda has done, or what Uganda has done, or what Tanzania has done, that Kenya is not doing.
Yeah, and again, we'll come back to that to understand, so that what is it that we can borrow, right, and make it work and localize it so that it works here in the country. But Stella, I'm just curious, listening to the numbers that, Dr. is giving us, what do you make of it? I mean, as a champion, first of all, what do you make of it? Like, do you think there's a lot of work that tunafaa kufanya, all of us, governments, healthcare services, and even champions as well? What do you make of those numbers?
Yeah, kuna kazi ya kufanya.
Yeah, okay. And so you are a champion, and just going back to your babies before we come back to because again, like you said, after your experience, you decided, you know what, I will go back and I will help women, to understand why it's important for them to, first of all, go for their antenatal care as early as possible, and have all these tests and scans done. And this is based from your experience. So you said your second child was born with, at 1,000 grams.
1 kg.
And then reduced to around 700 grams. One of the things that you were told is kangaroo mother care, which sort of like helped kidogo. What other things were you told to do just to make sure that na boost their weight kidogo, and both of them, not just this one who was born with 1 kg?
Okay. From 700 grams to 1.8, nilisaidiwa na hiyo kangaroo.
Oh, in a span of...
Yeah.
Okay. Ukiwa tu hiyo period bado ulikuwa hospitali. For how long? After amezaliwa until again to 1.8 kg?
Okay, kwanza vile alizaliwa, ndio apunguze, alikuwa na shida ya kupumua.
Okay.
Sasa vile daktari alikuja akanieleza about KMC. Nilianza na mmoja.
Okay.
Kwa sikuwa naona kama ni kitu inaweza kusaidia mtoto kuongeza weight kwa haraka.
Okay.
Vile nilianza na mmoja, within 1 week akaongeza hadi to 1.6. Nikajua nyewe ni kitu inafanya.
Yeah.
Ndio nilienda nikachukua mwingine, nikakuwa nawaweka wote wawili.
Okay.
Nilikaa pale 3 weeks, nikadisajua nikaenda home.
Okay.
Yeah.
All right. Na so vile ulifika nyumbani, nini uliambiwa in terms of like, kusaidia watoto in terms of their growth and development? What is it that you had to do?
Okay. Kwanza ule mtoto si mtoto kama wa kawaida. Unafaa umchunge side.
Okay.
Kuna dawa uanga anapewa. Unafaa umpe hadi daktari akwambie ni hivyo zimetosha. Pia hiyo KMC inasaidianga. Kwa sababu unapoweka mtoto kwa kifua yako, unamsaidia hata baridi simuingie.
Okay.
Yeah. Sasa unaona, instead of incubator, pia KMC inafanya better than incubator. Because incubator hata stima inaweza enda in time. but kwa kifua iko
The
sawa.
heat iko throughout. Okay, all right.
Sasa hiyo ilinitia nguvu ya kuongelesha hawa mama wengine wenye wamezaa low birth weight kwamba ni kawaida.
Okay.
Kwa sababu nyuma ulikuwa unasikia ukizaa mtoto preterm either uko na laana ama huyu mtoto hata waitembea ama hata waiongea. Hakuna kitu kama hiyo. Watoto wanakuanga sawa, wamechangamka, wanakuanga tu sawa.
Umesema wako saizi wako shule, wako grade 1 and they're doing so much better. Unasema wao ndio the brightest in class, which is really good to hear, because it's true like you're saying, wamama wengi wataangalia waseme sasa nitafanya nini, huyu hata kwa, there's a lot of myths and misconceptions.
Kitu kingine ilinitia moyo, na daktari alikuwa ananitibu pale. Okay. Siku moja alinipata, it's like I'm crying. Kaniuliza what's wrong? Kamuliza mimi hapa sina matumaini. Kaniambia hebu niangalie. Kaniambia mimi nilizaliwa na 1.2. Na mimi ni daktari sahi. Sasa hapo kachukua moyo. Even huyu mtoto nikamuita kama huyu daktari.
Oh wow. Okay. I really like that. Okay. So then I'll come back to you to understand. So is it that women say that is a big challenge, that hawafanyi maybe scan, hawaendi hospitali as often as they should? Is it a case of maybe hakuna the required facilities karibu na wao, ama ni, you know, the equipment that is needed haiko, ama is it a case of finances, you know? So we'll come back to you to understand that. But Daktari, again, based on what Mukali again is saying, there's a lot of myths and misconceptions. So number one, would want to understand, so what are some of the risks for this child who is an SVN? What are some of the, you know, potential risks that they are exposed to, and what is it that mothers can do to help the children so that, again, in as far as their growth and development is concerned, what is it that needs to be done?
Yeah, thank you. So I think there's a lot, well, I think there's a lot of health implications for a child who's born SVN. But before that, I wanted to highlight, just based on my previous conversation on the numbers globally, sub-Saharan region and then Kenya, but also to say that we often talk about mortality as a hard outcome. But also I think there's one thing that is probably not ever brought to light, is that there's a lot of mothers that leave hospital maybe with a newborn, but actually subsequently they're still suffering from other things. So there's also another burden due to infections, and even mental health as well. So those are things that I think, I don't think, I mean, mortality is one metric, which is obviously a hard outcome, which is obviously devastating. But also I think we really need to even consider, like, even women who are leaving hospital, there's also continued suffering in terms of the care looks like. There's a lot of women who leave hospital with a lot of complications. So I think infection, mental health, and there's things like fistula as well that a lot of women are silently suffering. So I think we really need, as a society or as a nation, to really think beyond the care that's provided at the hospital, but also how do we better care for women even after they've left hospital. I think in terms of what are the adverse outcomes or implications for SVN, I mean, I think the obvious one we talk about is mortality. So if your fetus is small for gestational age, during pregnancy, obviously there's high risk for mortality. Stillbirths, which you quoted, current estimates for stillbirths is about 1.9 million. Neonatal mortality we've been talking about. Infant mortality as well, which again we are looking at periods beyond just the time of birth, subsequently at 1 month, but even in the first 1 year of life. But also there's other effects which could come in future life, such as morbidity, lung damage to the child. So for example, if you have a newborn who's live, you leave hospital, but actually if they have deformation such as lung disease, then obviously they don't live a healthy life. So I think a lot of conversations has been, it's not just surviving the period of birth, but also thriving and having a fruitful life. So that's very important. And then other aspects of growth and nutrition, which is a space that I really work in. So we look at the growth of these children. So obviously we want the children to survive, we want them to thrive, we want them not to be faltered or growth faltering or stunting, which is another metric that is of importance, wasting and malnutrition. And there's a lot of studies that have shown that children who are, for example, stunted or wasted then end up performing poorly, even in class, for example. So they have lower educational outcomes, and perhaps even future potential outcomes as an adult in terms of the jobs you're going to get and your average income. So there's a whole load of things that I think...
It's like a full cycle.
As a full life cycle, that what happens at birth really could actually determine your trajectory, even throughout your adult life. And then there's also what we call developmental loss. So don't think, you should obviously encapsulate that we're having newborns who are born into the world and we want them to survive, to thrive, but also be economically useful to the society. And we know that children who are born with SVN are more likely to also have delayed in terms of motor development, so they're slower to achieve some of the milestones given based on their age, cognition, which again relates to things like educational outcomes, but also economic potential, childhood illnesses such as asthma as well. So again, there's a lot of things, and then in adult life there is risk for things like cardiovascular disease and hypertension.
Okay.
And I wanted to bring this concept. So there's a concept which was coined in 1990, which is called the Baker hypothesis. Okay. So this is now been this is in recognition by David Baker, who was a researcher who really coined this idea that actually predisposition, what happens in utero, so when you're actually pregnant, actually impacts even your future life. So this is called the Baker hypothesis. And now it's been formalized as what we call the developmental origins of health and disease. It's essentially saying that actually what you're predisposed, what your predisposition during fetal, at the fetal stage during pregnancy has implications throughout your life. So there's associations of a child who's probably born at SVN to their future potential in terms of their economic contribution, in terms of their future risk for disease such as cardiovascular and others. So I think the point of that is to say that the pregnancy period is a really critical period.
I see
it's
that.
a really
Totally
critical period.
that.
So I think we think of pregnancy as it happens now and don't think about what the implications of the future. There's been a lot of efforts based on this hypothesis of the Baker hypothesis, and even the formalization of conferences which are now called like the DOHAD, which is basically around the developmental origins of health and disease. So these are people who work in this space and linking what's happening at pregnancy to what's actually happening in adult life. So I think it's very, very important. What that tells us is actually we should really rethink the whole thing. And I wanted to use this opportunity to bring in a very neglected population, which is the adolescents, because those are our future mothers.
True.
So I think adolescents are usually neglected, so a lot of research usually focuses on children, mothers, and then children up to about 5 years, and then between 5 and 14, a forgotten population. But we're actually forgetting that these are actually going to be our future mothers. You know? And so I think we want to be able to rethink about what you're doing for adolescents, because we want to make sure that women and girls, as they're going through pregnancy, they are starting pregnancy with as a healthy adult. So I really think that in thinking about not just at the time of birth, we really need to actually go back and think about the period during adolescence as well, and how that contributes, because it's huge and it has implications for future life.
And Stella said, listen, these babies, they need to be closely monitored, and we're talking about SVNs in this case. So then what exactly does that look like? When she says you need to closely monitor, you need to take, I would say, extra care for an SVN. So very quickly, because I'm pretty sure there's someone who's watching us and thinking, okay, so then what exactly does care look like for them, and especially that period after leaving the hospital, and even as we monitor them into adulthood, teenagehood?
I think as Stella said, I think there is the current guidelines in terms of care. But if you have a preterm baby, for example, then you'll be closely monitored in hospital and only discharged when you reach a certain kilograms, which is what is used to determine discharge diagnosis. And then the women are discharged. And then again, this just brings another gap or hole in the whole quality of care and healthcare system. Is because we're not very good at actually providing postnatal care. And the reason for that is it's not only are we able to track the women that are being discharged from hospital, we don't have check-in points and saying, okay, this person has been discharged, they're a new mother, how are they doing? So I think the system is set in such a way that the women have to seek care, but there's nobody reaching out to them to see actually how well are they doing. Bring care to them, as opposed to expecting that women can actually come back to the healthcare system. And there are multiple of issues. One is obviously a lot of the healthcare system, sometimes you have to pay. And sometimes they probably don't, you know, there's also lack of information. So knowing that I probably should be checking in and taking and go for regular checkups again. So I think the whole postnatal care, I think we need to really strengthen those systems. Okay. I don't think we should be expecting that women will know that they need to come back for frequent checkups. Postnatal, and especially if you're born preterm, you need more intense follow-up in certain periods to make sure that nothing else is cropping up, and also they're more susceptible to infections and things like that. So I think, you know, the whole postnatal package and making sure we can actually reach out to the women where they are and having close monitoring in the health of their babies, I think is what is
because
needed.
There's a lot of disparities actually to that, because you'd find that there's some women maybe in rural areas who do not have, you know, healthcare facilities closer to them. So by the time they think, you know, going to the hospital or even reaching there, having the facilities or resources to get to the hospital, that's a very big challenge. So then we'll come back to you, Dr. then to understand, so what are some of these preventive interventions that should be there, you know, as far as SVN is concerned. But Rikali, very quickly, so what is it that women are saying is a big challenge for them? You know, when it comes to accessing care, shida kubwa kabisa ni nini that we need to tackle as soon as now, so that we prevent, you know, mortalities that Dr. has mentioned, and even, you know, cases here as well.
Kama kwa sahi, hii story na kutoenda check up, nimekuja kurealize hata wamama wengi si wa Kenya. Ni wakimbizi. Okay. Na unapokuja Kenya na unapatikana uko na ile mimba, wengine hata wanaogopa. True. Wasichana wengine ni wa kutoka kwa street. Wanabeba mimba na wanakaa. Kuna mama wengine unabeba mimba na maybe mzee anakutupa ama inakuwa tu whatever the case. Yeah. Sasa unakuja unapata huyu mama anabeba mimba na cause unaona anaongezea na ile stress. Mimi si Mkenya, nitakuja kuzaa aje? Maybe inafanya hata azaa haraka. Kama muda hujafika. Okay. Sasa ndio unawapata pale wengi wako na stress. Okay.
Nini nyingine tena like in affect so many women, especially wale pregnant, because again, like you said, for you at some point ulisikia tu uchungu and then you decided, you know what, let me just go to a hospital. Sindio, nione what exactly this is. Okay, before you know it, umesha deliver watoto wako of 6 months, which again that's pretty tough. So yeah, what is this other challenge that women face?
Okay. Wengi wanapitia stress. Stress inawafanya wajifungue kabla ya muda wa kujifungua kufika. Okay. Pia stress inafanya kuna changamoto mingi za stress. Okay. Wengine ni kutojikubali. Because most cases unapata ni wasichana wadogo. Sasa unapojipata hivyo na ukose kujikubali, pia inachangia.
Okay. All right. And what about like finances? Because again, Dr. mentioned there's some, unapata in some facilities kuna cost, and some women will tell you, but I do not have money for that. Some facilities, for example, mtu akitaka kufanyiwa scan, you know, you have to pay some amount, of which some women would say, I do not have, you know, that kind of money. So nipatie tu dawa.
Okay, pia hiyo inachangia cause. Unapata kama huyu msichana ako kwa street, ana pesa kwenda check up. Kuna mwingine maybe ni wa shule na anajaribu kuficha mzazi asijue. Pia atapata nafasi ya kuomba ile pesa aende. Unapata tu wengine ni shida ya pesa. Pia inachangia kwa sababu na ukienda pale bila pesa huwezi hudumiwa.
Okay. So in your opinion, nini inafaa kufanywa sahi to help women who are pregnant, again, to reduce cases za SVN? What is it that needs to be done now, either from, you know, the government level to a local level, hata kwa facility?
Okay, mimi kama mama naweza sema story na kushughulikia mama wako na mimba ikuwe free. Okay.
Someone said kuna linda mama in public hospitals, some of some ni free.
Okay, linda mama pia iko. Na kama una ID, huwezi pata linda mama. Okay. Of which nimekwambia wengi ni wakimbizi. Sasa unapata pale unangangana na mama, mimi nimetoka, mimi si Mkenya, sina ID. Hiyo ndio ilifanya nisishughulike na linda mama. Kitu kama hiyo. Wengine ni watoto wa shule na ile kuficha mzazi asijue. Unapata ile muda wa kujifungua imefika na ana linda mama. inampata. Yeah.
Okay, so you're saying access to like antenatal care in effect we're free for all women.
For all mothers.
Okay, all right, I see that. So Doc, what are some of these interventions, and just picking up from what Stella is saying?
Yeah, so I think as part of the Small Vulnerable Newborn Lancet series, this was work that was done, and I think in thinking about this with the main focus being prevention. So the series focused on 5 things. One is, we wanted to understand SVN and the traditional indicators such as low birth weight preterm. So that was kind of bringing the series together and summarizing that. Was capsulated in paper 1, and then paper 2, which we led, was basically the numbers and understanding where we are and the burden. And paper 3 was understanding the mechanisms that lead to SVN. And then paper 4 relates to your question, which was interventions. And I think the idea was not to think of new interventions, is to think about proven interventions. So there's a lot of research that's been done, and I think the idea was to see what are some of the proven interventions that have been shown that could help SVN. And I'm just going to highlight some of those. So some of the proven interventions that could be applied to all women are things like screening and treatment of syphilis. So that's something that is a proven intervention and is helpful during pregnancy, but also the provision of multiple micronutrient supplements. Again, supplementation during pregnancy. I think multiple micronutrient supplements during pregnancy is recommended. In Kenya and a lot of other countries have policies where you have supplementation, whether it's based on whether you have calcium and folic acid and others. Those are already proven interventions.
For folic acid, and then that's
yes, folic acid.
As long as I pour folic acid.
Exactly. So I think we need
to
more than that. So it's not just folic acid. So I think the having this multiple micronutrient supplements, I think it's something that is applicable across all women.
Yeah.
And then obviously
administered for free, I hope.
Well,
that is what she's saying.
Yes, I mean, again, those are things. I mean, I think Kenya has a national policy whereby every woman who appears during pregnancy should be given, I think, folic acid and probably calcium. But I think there's a push towards macronutrient supplementation, which, again, there's probably a cost to that. And, those are things that probably the government could be able to come in. But that's the blanket. That's a blanket intervention that have been shown to work across all women.
Okay.
But obviously we know that there are pockets of women with special characteristics that require different interventions. So these are proven interventions for select women. So for example, we talked about some of the risk factors, like for example, smoking is one of them. So I think thinking about things that are specific to women who are smokers, and we know smoking has impacts on maybe having a low birth weight baby, having insecticide-treated bed nets, again, in malaria endemic areas, for example, that could be specific to certain regions of the country. Low-dose aspirin, which has been shown as well to be to actually help. Another thing such as provision of progesterone. So I think those are proven interventions. We are not talking about new interventions. This is where research has been done and there's been shown to be impact on the pregnancy. And then I wanted to move on from those specific interventions. Really, I think the key to this is actually having quality and access to good quality care. Okay. And I think that's another thing. So that's something that it is not easy to define. What is quality? What is a good quality of care, but also access. So I think we really need to think about what is, as for example, Mikali, her experiences going to hospital, the care that she received. Yeah. Is it of good quality? Because it's not up to her to decide whether I want to have a scan or not. It should be like a standard, right? Exactly. Yeah. So I think, and if you think about quality of care, you're thinking about, for example, early ultrasound is quality of care, because that should be universal, standard, and available across for all women. Having early antenatal care and follow-ups, those are kind of things that are going. Those are things that contribute to the quality of care, but also at the point of delivery, the quality of care that you get, and depending on the status of the pregnancy. So I'm going to just give an example. For example, if you're having an elective C-section, for example, how we decide whether somebody is having an elective C-section or not, and who pays for that. I think in other settings that becomes a challenge for most families, whereby elective C-sections actually have huge costs. So I think that's the quality of care, and we really need to define what that care is, both from very early pregnancy, ultrasound, follow-ups, and at the point of delivery. Okay. And then the last one I'm going to say is about the societal level action. I think we have a responsibility as a society. So I think the whole prevention of, if you're going to make any impact, it requires a multi-sectoral approach to the health provision. So it's a coordination of even women champions like Mikali at the societal level, because they're in touch with the women at the local level. They understand their issues, their problems.
And it's also easier for her to communicate to this women in
Exactly,
language that they can understand.
So she's able to communicate. She understands their issues. She understands their problems. There is the health sector itself. There is the government, the infrastructure that allows the women to get to hospital. So I think this requires a multi-sectoral approach. So I think having even women champions, the healthcare system being receptive to the women and not discriminatory in any way. I think those are some of the things that can be done that can be done.
All right. And I'm just curious to understand, especially for those regions where, again, like you said, they have made like 70%, you know, impact on the same, and for us we're only at what, 33%, which is very concerning, if we can say. So what is it that has worked there? What is it that we can borrow, aside from these interventions that you've given us this morning? What is it that we can borrow, and especially when it comes to strengthening our healthcare systems right here in the country, because there's a bit of disparity there's some regions where access to healthcare is no big issue, but for some women they have to walk long distances just to access healthcare, which is enshrined in our constitution as a right for everyone.
Yeah, I mean, I guess that's the $1 million question. I think there's a lot of things. So I think there's a lot of issues that obviously impact on this. One of them is infrastructure. Especially in, for example, in rural areas where, for example, women have to walk long hours to be able to get access to the next health facility, and that depends on the healthcare. We also thinking about the health facility and how equipped they are to deal with these pregnancies. And I think the whole idea where we've talked about access to healthcare, I think, is really important. Getting women to come early during the pregnancy is hugely important. And also removing barriers for women in terms of either if you have to pay and make those decisions around financial cost associated with any pregnancies. So I think I think that requires a lot of not just the infrastructure from the government, but I also think like we really need to go into the grassroots. Community health workers, education, community health workers have a really key role to play in that agenda as well.
I see that.
I think in other countries that have been successful, I would say that probably, you know, the access to early ultrasound, I think, is one of them. Early antenatal care is another. And then some of these interventions as well could help. But also, I think it's also educating more women. I think if you look at education levels, for example, in the different countries, I think that also contributes in understanding pregnancy, what you're going through, and when to seek care.
Absolutely. All right. So, Mikali, as we bring this to a close, and having gone through this experience, I know, of course, you have learned so much from the same. So what is it that sounds like he'll do different based on, you know, the things that you have learned, and that you're also passing to, you know, all these women that you also help during this journey, because it's a journey and it's not an easy one at that, but to know us idea. So ni lessons gani you've learned that you will take forward? Because I asked, do you have other children? Say, you know what, I'm okay for now. Okay, so very quickly, what is it that you said you have learned that you'll take forward very quickly before we end the show?
Ile kitu nimesoma pale, hata after wamedischargiwa au wamama sasa, wengine hata wakujangi clinic. Mtu anaenda na anaenda akiendanga. Sasa inakuanga jukumu yangu kufuatilia huyu mama. Inakuanga jukumu yangu nimtafute. Nijue unakuja clinic ama nimwambie unakuja clinic tarehe fulani, masaa fulani. Asipokuja, it's my duty nijue
kwa nini
ukukuja. Kuna pale tunakuanga na kliniki yetu. Mpaka mtoto akikuwa mkubwa unaweza ambiwa uende to the nearest. Sasa pia huko karibu inakuanga jukumu yangu nifuatilie unaendanga. Pia kuna ile kukamulia mtoto mpaka afikishe 2.5, that is normal body weight. Pia ni jukumu yangu nijue mama wakati ulidischarge ukafika nyumbani unakamulia mtoto ama unanyonyesha. Kwa unapatanga ni kadogo kananyonya, ndio kananyonya but akashibi. Anatumia nguvu nyingi, analala, unafikiria ni kushiba ameshiba na ni kuchoka amechoka.
I see that.
Hata ongeza kilo. Sasa unapata hata wengine mama anakukola na kuambia, imagine nimefika nyumbani na mzee anakataa nisikamulie mtoto. Mimi si mbuzi.
All right.
Ni jukumu yangu pia niombe namba ya huyo mzee, nimpigie simu, nimweleze
Ufuatilie.
umuhimu wa kukamua.
All right.
Yeah.
Okay. So that was akishatoka hospitali tu hamwachili. Una make sure that okay.
Mpaka afikishe 2.5, that is normal body weight.
All right. Sawa, Stella. Thank you so much. We'll unfortunately have to end the conversation here. But Dr. Thank you so much for your time. And Stella as well. Thank you so much. Dr. Erica Huma, Associate Professor at the School of Hygiene and Tropical Medicine, as well as Stella Mikali, Champion Mother Pumwani Maternity Hospital. I hope that you've learned a lot from today's conversation. Have yourselves a lovely day ahead. I'll see you tomorrow morning, same time, same place, right here on your world. Until then, stay safe. Goodbye.